My task really is to look at the relatively modest number of patients who are eligible for liver transplantation as treatment for their hepatitis, for their hepatocellular carcinoma. And shown here is really the sort of start of it all, in the sense that this was the landmark study that was published back in 1996 that showed that transplantation could be an effective therapy for small HCC. And so were born the Meld criteria, which established the characteristics in terms of size and number that yielded a 5-year survival that was in the 70 to 75% range. The Meld criteria have endured. They are defined by a single tumor that's not more than 5 centimeters, or up to 3 tumors, but none of them greater than 3 centimeters without vascular evasion or extrahepatic spread. The transplantation community really embraced this option. And over time, HCC has become the primary indication for transplantation in about 1/3 of all the transplants. Shown at the top are the results from the UNOS database in the United States, where it accounts for about 30% of the transplants. And of those 30%, hepatitis C still remains the most common etiology that underlines HCC, even though it has been on the decline. You can see in the United States, it still accounts for about 45% of all the HCC transplants. Shown on the bottom are data from the European Liver Transplant Registry, and similar to the US, you can see that about 30% of the transplants are indeed due to HCC. Again, even in Europe, we still see that hepatitis C predominates as the cause. But in both the US and in Europe, we're seeing that NAFLD is now on the rise, and in most centers is the indication for which we've seen the greatest increase over the past 5 to 10 years. It's important to remember that in the individual who's undergoing transplantation for HCC, that the reason liver transplantation is being chosen over resection is that they have advanced liver disease that would prohibit resection as a therapy. And so when you're looking at post-transplant survival in the transplant setting, that reflects, and also waitlist survival, it reflects both their underlying liver disease as well as the potential prognosis of the HCC. And what's interesting is we now are looking at post-transplant survival in the DAA era and seeing that indeed our overall survival in the patients who are transplanted for hepatitis C and hepatocellular carcinoma has improved, likely reflecting our ability to manage the HCV component of their disease post-transplant. So I'm just showing here really that from that original publication that several other centers and multiple analyses confirmed that the Meld criteria are very effective. Here I'm showing data from the so-called Meld era, which was from 2002 onward. This is an important landmark period of time because that's when really HCC became prioritized for transplantation in the United States. And so there was a rapid rise in this as an indication for liver transplantation. But what you can see as you look down the group, comparing the no HCC group to the HCC with Meld exception, and looking at them by those that were also greater than 2 centimeters, you can see that overall the patient survival at 4 years is comparable in the no HCC versus HCC group. Overall, there was about recurrence at this point in time in about 10% of patients, and the consensus from these initial results in the early sort of years when this was gaining momentum was that this was an effective therapy for patients with small HCC. Now, when you prioritize patients with HCC for transplantation, you have the downside of potentially having patients who don't have HCC but have decompensated cirrhosis waiting and competing for those same organs. In the United States, this became very, very obvious because we over-prioritized cancer in the early days. So shown here was an analysis done in 2012 that just shows the difficulty in trying to prevent a disparity from emerging in which the patients with HCC have easier access to transplantation than patients with advanced liver disease. Shown on the graphic on the left is really what happened in the early years, in the first 5 to 7 years of when we prioritized HCC, and you can see that certainly patients without cancer, which were much more likely to die on the waiting list than patients with cancer. And that's led to various changes in the United States and I think elsewhere in terms of how we give allot points or Meld scores to patients with HCC. And shown in the table on the right is just reinforcing that patients who didn't have HCC were at higher risk of mortality. In the United States, where we have a national policy for how we prioritize patients for transplantation, you can see that from 2002 through to 2015, we've continued to evolve the criteria on how individuals are prioritized with HCC. And the whole point of this system was really to try to, as I just highlighted, remove the disparities such that patients who had advanced liver disease, decompensation with high MEL scores could access transplant in a timely fashion, and that we weren't over-prioritizing the HCC patients. So for example, back in 2002, it was strictly based on if you had a T2 lesion, you would get 29 MEL points. If you had a T1 lesion, you got 24. We did away with the T1 exception in 2004. And then in the most recent iteration, now patients, when they're first diagnosed with HCC, have to wait 6 months before they can start to gain points for that diagnosis. Then they get 28 points. They increase sequentially every 3 months, but they maximize their MEL score at 34, so that patients with decompensated cirrhosis who have higher MEL scores will always get access earlier. The consequence of these changes is that in the United States is that our patients with HCC are now waiting longer to get a liver transplant. They have less access, which is appropriate given the landscape of limited organs. But that does mean that we also have to bridge patients for longer periods of time from diagnosis to transplant. And that can be an issue in areas where there are really long waiting times, and in California, that is one of those regions. This was a study that showed that waiting time can influence your risk for both dropping off the list because your tumor progresses, but also probably influences the risk for recurrence post-transplant. So shown on the left is evidence of HCC recurrence. And what it's looking at is that recurrence based on the amount of time that the patient was on the waiting list. So this is looking at post-transplant recurrence. And you can see there's two sort of peaks. One is those that were transplanted within 6 months of being listed. And then after about 18 months, there's also a slow rise upward in terms of the risk having higher rates of recurrence. This led to the concept that there's sort of a sweet spot in terms of when it's ideal to do a transplant. At some level, you don't want to do a transplant too rapidly after they're listed because it probably doesn't allow you to see the natural biology of the tumor. And whereas if you wait longer than, say, 1 year or 18 months, then obviously that's a very long time to be trying to bridge somebody, and the chances that their tumor biology, again, will be such that it'll be put them at higher risk for recurrence post-transplant. And shown on the right is indeed the analysis that showed that those that waited between less than 6 months or greater than 18 months had a higher rate of HCC recurrence, 15.5%, compared to those that were in that sweet spot where the risk for recurrence was 9.8%. So with the success of Milan, it was very rapid that programs undertook expanding the criteria. If we were doing so well within Milan, the question was, could we expand this modestly and still get acceptable survival? And I'm going to just cover two of the sort of very frequently used criteria. One on the left is the UCSF criteria. That criteria was where a single lesion could be under 6.5 centimeters or 2 to 3 lesions, none exceeding 4.5 centimeters or a total tumor diameter of 8 centimeters could be included. And shown in the left is when they looked at post-transplant survival in those that were within Milan versus those that were within the UCSF criteria. You can see that the post-transplant survival was similar. And indeed, they showed also that the risk for recurrence was also similar, so showing that a mild expansion of the criteria could yield acceptable results. And shown on the right is the up to 7 criteria. This may be used a little bit more frequently in Europe. Here, the criteria to being eligible for transplant is that the sum of the size of the largest tumor in centimeters and the total number of tumors can't be more than 7. And again here, shown on the right, is that compared to patients that were within Milan, those that were outside Milan but within the up to 7 criteria had comparable rates of post-transplant survival. But if you went beyond the up to 7 criteria, then you started to see a decline in survival and really fell to a level that's not acceptable for liver transplantation. So sort of pushing the limits and finding out where those limits are in terms of yielding acceptable survival. Now, if you look across many countries, you'll see that there is really a lot of variability, but I put this table up not to really focus on any one, but really to highlight what other criteria are being used. So Thus far, I've shown that really size and number are the criteria that are primarily used to determine candidacy for liver transplantation. But as we go down, for example, in Toronto, they don't use tumor size or number, but they use a liver biopsy and the degree of tumor differentiation to influence their decision-making. You can see that in other programs, such as in France, that they're using alpha-fetoprotein criteria as a primary driver of decision-making, and others are using AFP as well. And so really, what I want to shift to is that as we are trying to expand the criteria for liver transplantation, rather than relying solely on number and size, we're also bringing in other biomarkers. And alpha-fetoprotein has shown itself to be a useful biomarker in this setting. Here I'm showing you results across both multi-center registry data as well as single-center and multi-center results. And although the cutoff varies, sometimes they use 400, sometimes it's 1,000, sometimes 800 I use per nanograms per deciliter. You can see that the trend is always the same, that individuals who have higher AFP have higher likelihood of developing recurrence. And actually, data also shows that they have a higher likelihood of falling off the list while they're waiting due to tumor progression. So that's one criteria, having a biomarker like AFP. And then the other is looking at the response to local regional therapy. And in this regard, the transplant community has really borrowed the RECIST criteria, this idea of looking at when you do a local regional therapy, how much viable tumor is left. And increasingly, the viable tumor is now being used as the criterion to determine whether a patient is within or without malign criteria. So shown here is this ability to sort of measure in a very rigorous way whether someone's had a specific response to local regional therapy. So an example of how we can use the response to treatment in an assessment that might help us yield better prognostic information. I'm showing you here data from the Metro Ticket 2.0. This was a multi-center study from 3 centers in Italy, over 1,000 liver transplant recipients, most of which had undergone local regional therapy. And most of them had been sort of downstage to be within Milan criteria on last imaging. And what they looked at here was the ability of those individuals to be able to get to transplant, and then to look also at the post-transplant outcomes. And you can see that they did a competing risk analysis here so they could look at what's related to death from HCC recurrence and what's related to underlying liver disease. And then they did an external validation. So a very nicely done study. And what they showed here is that the best predictors of prognosis were 3 variables. One was the number of viable tumors. So here they're looking at the response to local regional therapy plus the diameter of the largest viable tumor plus AFP. So we can see that we're shifting from relying on that initial size and number to looking at response to therapy and incorporating biomarkers in terms of helping us to prognosticate. And they came up with a very nice diagram that sort of highlights the post-transplant survival in these individuals based on various AFP levels, as well as the viable tumors seen after local regional therapy. And I think very important, in the simplified diagram on the bottom, it shows the importance of AFP. And you can see that in their series, any patient who had an AFP greater than 1,000 at the time of transplant basically didn't do well. All of them developed recurrence. And many transplant programs have now adopted a greater than 1,000 as being an absolute criteria not to do liver transplantation. But you can see that even at lower levels, there is sort of a trade-off in terms of the risk. And many now are incorporating change in AFP also into the criteria for liver transplantation. Now, I want to just spend a few seconds on this downstaging idea where you take a patient who's outside the Milan criteria, you treat them to get them within an acceptable criteria for liver transplantation. And initially, this was really a very kind of radical idea, that you could downsize patients' tumor burden and still anticipate that you'd have good outcomes. But indeed, that's been shown in transplantation. Now in, for example, the United States, across the United States, we now have so-called criteria for downstaging. So if we have a patient whose initial tumor size falls into one of the 3 in the purple box, say a lesion 5 to 8 centimeters, 2 to 3 lesions or 4 to 5 lesions, but the total O is less than 8, that person becomes eligible for downstaging. So what's the success of this downstaging approach? And in this analysis, which is really very recent, just presented at the ASLD, it really shows comparing Milan, patients who were in Milan at baseline when they entered, those that started out outside and were downstaged, and then so-called all-comers, so people who are outside even the UNOS criteria for downstaging but still underwent transplant. And really, this is 10-year outcomes, and really it shows, I think very importantly, that those within Milan and those downstaged actually have very good outcomes. But when you go beyond Milan or beyond that downstaging capability and have a patient who's transplanted who hasn't been downstage appropriately, then you can see a significant reduction both in survival as well as in recurrence. But for those individuals who are appropriately downstage, those individuals generally we're seeing very good results to 5 years. We see some separation at the 10-year mark, but overall still acceptable results from the point of view of transplant. Now, in the last minute, I'm just going to touch base on recurrence. So this is a summary that just highlights that across many studies, we have a recurrence rate that varies from 9 to 18% with follow-up periods of 3 to 5 years. Most patients recur within the first 2 years. They can recur in the liver or outside. Most commonly, it's outside the liver, and the most common sites are lung and bone. Overall, our success in treating these individuals is very poor unless they are resection candidates. So shown here is the median survival in patients with post-transplant recurrence based on the treatment that they were eligible for. And you can see really the only treatment that yields success is resection. And for this reason, there's been now a kind of a move towards trying to do surveillance so that we can detect recurrence earlier with a view that we want to try to detect individuals who can, in fact, undergo resection. And increasingly, surveillance is now based on cross-sectional imaging plus AFP. Recommendations are to do it every 6 months for at least the first 2 to 3 years, and that you should consider doing a CT scan of chest as part of surveillance given the frequency with which lung mets are the initial presentation. This is just an algorithm that just highlights that both with hepatic and extrahepatic manifestations, we really are looking to have those individuals be a resection candidate. That should always be the go-to therapy. But otherwise, really we're doing basically local regional therapy to try to control disease or moving to systemic therapy. Just one caution is that the anti-PD-1 drugs have really not been shown to be safe in the transplant setting, with several reports of rejection leading to graft loss. So that's probably not an option in this clinical scenario, at least with our current information. And then I'll close by just highlighting a very nice review article that points out that if we want to prevent HCC recurrence after liver transplant, that it's not a matter of just selecting the patient. That is key. But also it's how we do the surgery and minimize the risk for tumor cells being released, how we manage our immunosuppression after transplant, and how we consider use of anti-cancer drugs in this setting. So to summarize, liver transplant is an effective HCC therapy for well-selected therapies. Within Milan criteria, those downstage to within Milan have excellent 5 and 10-year survival. We're now moving away from just size and number towards incorporating biomarkers and response to local regional therapy. Waitlist drop-off is still a major issue. For those that recur, they're going to recur usually within the first 2 years. Their prognosis is really pretty dismal. Ideally, we want to catch them when we can offer resection as the treatment, but clearly our primary goal here is prevention. And in that regard, more studies regarding the safety and efficacy of HCV-specific therapies in liver transplant patients are needed. Thank you very much.